I mean, just, it's not for the good part,
Yeah.
right?
I understand what papers was.
I mean, you're derogating.
Yes, when you're hard, huh?
Yeah, it's,
Sundance.
yeah. No.
Test. All right, hopefully everyone who's on the call today can be able to hear us. Welcome to this meeting on September 17th. We'll go ahead and get started. We are waiting for a few board members to join the meeting in order to achieve a full quorum. But at that, we'll just continue the meeting from the beginning here. And we're going to get started. So this, let's see, what, go through the slides. All right. So I'll just read the introduction script. It says this meeting is being held virtually and is hosted by the Utah Department of Health and Human Services, Center for Medical Cannabis based in Salt Lake City. We also are in person at the multi-agency state office building. So public notice of this meeting is provided as required under Utah's open meeting laws and was posted on the Utah Public Notice website. In compliance with Utah open meeting law, this meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. A rough draft copy of the unapproved written minutes will be posted to the public meeting website within 30 days of this meeting. Approved minutes will be posted to the Utah Public Notice website no later than 3 business days after board approval. Every proposed agenda item must have a 1-page summary of the topic submitted to MCPAB@utah.gov no later than 7 days prior to the board meeting. Board members will present the 1-page summary during the board meetings, and board members will discuss the summary. If no written summary is provided to board members, the relevant agenda item will be removed from the agenda. Only items that have been submitted in writing in advance of board meetings will be allowed during the discussion by the board chair, including presentations from the public. Board members will then request additional presentations and memorandums on the agenda items from relevant bodies to be presented at the next board meeting. Those presentations and memos will also need to be submitted to MCPAB@utah.gov 7 days prior to the board meeting. Public comments will be limited to 2 minutes per person. If you want more time, you must request it from the chair. The chair may accept or reject requests for additional time. A public comment period is not guaranteed every meeting. The chair has the authority to create or remove public comment period from the agenda or during the meeting. You can look at the public comment guidelines that are posted on the Utah Public Notice website. Please state your name and your affiliation when making a public comment so it can be reflected in the meeting minutes. Only comments made on items listed on the agenda will be considered. If you have a comment about an item not listed on the agenda, please email them to mcpab@utah.gov. How to make a comment over Zoom. The Zoom public chat will be disabled during Zoom meetings. When the chair indicates it is time for public comments, you will use the raise hand icon on Zoom to indicate that you would like to make a comment. When you are called on, you will be taken off mute. Take 2 minutes to make your comment. How to make a comment if you're here in this room. Sign in on the public comment sign-in sheet with your name and indicate what agenda item you want to make a comment on. The chair will indicate when it is time for the public comment period. The board chair will call on you when it is your turn and you will come to the public comment table. Take 2 minutes to make your comment. As a reminder, if you are in person, please do not speak when others are presenting. Our mics are very sensitive and those attending over Zoom cannot hear when there is more than one person talking at a time. Side conversations and comments from the public during this board meeting are prohibited. Please use a voice that is louder than your typical one when speaking, commenting, or presenting. When you speak, please lean towards the table as if there were a microphone. For additional information, to make a suggestion to agenda items or to contact board members or staff, send an email to mcpab@utah.gov. We'll go ahead and get through the agenda. Next item is the approval of the minutes. Did everyone get a chance to review the minutes? If so, are there any changes you'd like to make? If no changes, looks like we do have a quorum now. We will go ahead and would like to make a motion.
I make a motion to approve the minutes for July 24th.
Thank you. Motion's been seconded. Let's see, we'll do a roll call vote on this one. Abby? It's also, yes, well, we can do it, I guess we can, we can do it, we'll just do a voice vote, all those in favor? Aye. Okay. All right, let's see. So moving to the administrative business. We do have a couple items on here to discuss. One of the things that was brought to our attention is last month, the policy advisory board meeting was canceled. And although it should be set up to where you should be notified that the meeting has been canceled automatically, we found that it could be that your email was removed from the list. So please take time to resubscribe. We have implemented a new policy and a new process that if the meeting is ever canceled. We do have the list of typical attendees and those who have subscribed, and a personal email will be sent to all those to notify them specifically of the meeting's cancellation. And then we have changed the process as well to modify the meeting agenda, so it does show canceled. So there's some steps that we've learned in there. The second item on in here is we're getting to the point with our meetings where they coincide with the medical cannabis working governance group. And those are the legislators that meet every 2 months to discuss any policy or legislative changes that we're going to be trying to work towards for the 2025 legislative session. And so coincidentally enough, our meeting does fall on the same day that they meet. And so typically we finish our meetings around 5, our meetings begin at 4. What we would like to do is for at least the October meeting, instead of meeting at 2 p.m., we'd like to just move our October meeting to 1 p.m. That way it would allow us to finish at an appropriate amount of time to be able to get up towards the Capitol for those that do attend those meetings in person. Does anyone have any, this is also the board, is anyone okay with that movement? Yes. And then we'll send out an email as well to remind everyone on that. Will that work for you, Cammy and Des? I was looking up. Okay.
Yeah, it'll work for me.
Perfect. That's really all the administrative business we have, and I'll make sure that those not in attendance today will be notified of that change for the next meeting. Okay, with that, we'll move on to the next item, which is the Department of Health, Human Services, and Utah Department of Agricultural Food update. We'll first turn time over to Mr. Alderman.
Great, thank you, Chair. I'd first like to just introduce someone that's joining us for the first time today, and that is a representative of the Department of Health and Human Services, the Division of Licensing and Background Check, Shannon Toman Black. Shannon, would you introduce yourself to the group really quick?
I think that, as Rich said, Shannon Toman Black. I am the director of the Division of Licensing and Background Checks here because we were fortunate enough, Center of Medical Cannabis has moved into this division. So happy to be here and support this work.
Well, thank you.
Great. Other items, just some general statistics for the group that we track. The number of active medical cannabis cardholders is now 89,284. QMPs that participate in the program, we're now at 976. And the pharmacy medical providers, that number is now at 76. Also, during the past month, we launched the new electronic verification system in Salesforce, and that launched on August 12th. And thanks to those who assisted with the testing of that system and with the training that we did, we're glad that we were able to get a lot of participation in those training meetings that we put together virtually. And we thank the medical clinics and the pharmacists and the pharmacy agents at various locations that were able to help us with that. It would not have been possible with all that help. So we are glad to get help from medical providers and medical assistants at medical clinics and those other facilities. So also we did do a feedback session after we launched on August 16th. And we think those that participated in that gave us feedback after we had launched. It was good to be able to get that quick feedback. And so thanks to those of you who were able to join that. Also a big announcement is we have a draft rule, the R33-16 relating to qualified medical provider targeted marketing. That is in the handouts posted online. And also for those of you who are here in person, we have a printed copy. And if you remember at the last meeting, we got some feedback regarding that. And we were able to also get some feedback from our executive office. We made a few little changes that were mostly just design. And so the newest version of that draft is the one that is there as a handout. So if anyone has any questions about that, you're welcome to contact us. We don't have a hearing scheduled yet, but there will be a public hearing where any stakeholders can make comment about that rule filing once it's filed. I expect it to be filed the next few weeks. Has to be filed by, it's mid-October, so it'll for sure be done by then. And we can give an update at the next meeting in October about where that's at. But if are there any questions about that filing? I'm happy to answer those after the updates, but that's just to draw your attention to that rule draft. Also, we are setting up a cannabis medical provider quarterly meeting. This meeting will cover topics that will help Utah qualified medical providers, the qualified medical provider proxies that work in those medical clinics, and also pharmacy medical providers. It'll help them stay up to date on any laws or rules, and also just on the program in general. And we felt like it was important to gather that group at least a quarterly basis, and these will be virtual meetings, and we'll be sending out invitations to that either later today or tomorrow. And the first meeting will be held on October 10th at 10 a.m. And we'll be able to, and it won't be a public meeting, it'll just be for those QMPs and pharmacists that are participating in the program. But it'll go to all of those individuals that have those registrations with our program. Also, coming up, we're participating in the Utah Fall Conference on Substance Abuse. That's on October 24th. Dr. McKiff will be representing us, and I'll be there as well. And his topic is he's presenting on strategies for safe use of medical cannabis. And so we're hopeful that there'll be some medical providers and individuals that work in the substance abuse field that will benefit from that session that's going on down in St. George is where that's held. Also, just by way of update, during the past month, we've done some trainings. One of them was done with the Utah Osteopathic Medical Association. That was just on medical treatment basics or medical cannabis treatment basics. And then also during the past month, we attended the annual pharmacy assistant, or not pharmacy, physician assistant nurse practitioner conference that was at Snowbird. We had a booth there and we were able to interact with a lot of nurse practitioners, and Chris Morgan attended that with our staff. And we were glad to have his help at that meeting. Also, we presented at the University of Utah Internal Medicine Faculty Leaders group of about 25 University of Utah Internal Medicine faculty were there. And also we presented at the Utah Valley Family Medicine Residency group to about 25 or 30 residents there. Also, later this month, the University of Utah Center for Medical Cannabis Research will be posting 3 educational videos to help with educating patients and healthcare providers about medical cannabis. The first video is how to talk to your healthcare provider about medical cannabis. And so we have our physician that we've contracted with, Matt McKiff. During that video, he'll be talking about how a patient can prepare for their first appointment with a QMP and what that appointment looks like. They're also a second video they're doing is how to talk to your patients. So that video is specifically for medical providers, to help them know how to walk their patient through talking about medical cannabis. And then how to talk to your pharmacist. This is intended to help the patient learn what they need to know when visiting a medical cannabis pharmacy. And we're excited we were excited to collaborate with the University of Utah on those videos, and we'll let you know once those are posted. But we hope those will be good resources to not only patients, but medical providers as they learn more about the program and learn how to talk to their patients about medical cannabis. And we'd be interested in getting any feedback once those are posted from the board or from stakeholders. And also, last announcement is I've circulated some handouts, but there's extras there. These are some handouts that we have been giving out at the various presentations that we've been doing. And this just gives you an example of some resources that we're sharing with some of the public and medical providers about the cannabis program, so you can see. And also, if there's any stakeholders that would like copies of those, we can make sure you get a digital copy so you can print out your own. And that's all from the Center for Medical Cannabis. Are there any questions about items covered?
Yeah, I did have a question about the EES. If you guys completed the migration of all data, I know initially there were some issues with not all the data having been migrated over. Is it all now been migrated through the whole system?
It has been, yes. And if there's anything that's for some reason incorrect or not quite sitting with one of the pharmacists that's reviewing or pharmacy agents, you're welcome to reach out to our team and we'll investigate and take a look. Yeah.
And then question on this, the QMP target marketing role.
Yeah.
How does this compare to the other target marketing roles that are out there?
Yeah, so there is some specific language that relates to, for example,
Well, one, which starts with affiliating with medical offices, engage, right? I think that's on that.
Right. Right. So, yeah, of course, this is just written in the context of applying to qualified medical providers. So you're right. It's not just the medical providers themselves, but it also applies to the medical offices that employ them. There's a phrase at the end here that's paragraph 4 states the Department of Health and Human Services may approve terms or images otherwise prohibited if the target marketing does not promote the recreational use of cannabis. So, for example, it could be that there's those terms that are prohibited, but if they're using the term in a medical context, like, I don't know, it could be that it's a medical clinic that's called joint repair or something like that, right? We know they're not talking about the joint in the context of recreational use. They're talking about joints as in a name or as in the medical term. So that is something that's a little bit different.
Okay.
And again, you're welcome to review these on your own and contact us later with any questions. And then we'll let you know once there's the formal opportunity to submit any comments. Once that opens up, anyone in the public will be able to submit comments.
Thank you. All right, go ahead and Cody, you filling in for Dr. Forsythe today?
I have.
Mr. James, report.
Thank you. Cody James, Deputy Director of the Industrial Hemp and Medical Cannabis Division at the Department of Ag and Food. We know and we appreciate that the board moving this meeting to earlier in the day because there was supposed to be an Executive Appropriations Committee meeting this afternoon with the Department of Agriculture on the agenda. That has been removed from the agenda, so there was, after all, you don't need to do that. But we do appreciate that as well. But along those lines, Dr. Forsyth is actually up there today. The majority leadership for the Executive Appropriations Committee has asked him to come up and answer some questions about the topic. So that's what he's doing this morning up there to see what I guess the next steps moving forward. So I'll ask you guys to get to deal with me today. And only me. I don't have quite the beard Dr. Forsyth does, but I have less gray in mine, so it works out.
Better had a hair though.
That is true. Thank you. Thank you for noticing. Just a couple of things really quick, talking about some rules. R66-2, the cannabis processor rule, as well as R66-3, the quality assurance testing on cannabis rules that we brought to this board a couple of months ago. Is currently in public comment. It's open. The public comment should close on October 1st, I believe. And so we should be able to see those come into actually being put out there on October 8th. There is when they should come into effect. The closed door pharmacies rule, which we've been working on, has had to take a back seat to a couple other things there, but we're hoping to do our final internal review of that rule tomorrow and have it to this board for your October meeting to be able to move that forward as well. And hopefully we'll have an application at that point as well. So as soon as we get the approval to put that rule into place, then we'll be able to have any applications open for that as well. So, and then probably the last thing just to mention is the ICS portion. As y'all know, that's kind of been getting pushed back. The last date that I have been told is that it's looking like it's October 15th. And I also heard yesterday that looks like it's a pretty solid time frame. But as we all know, it's based on that. We'll continue to see how that works out. And that decision will come from Dr. Forsyth and his team working on ICS.
And that's just for the supply side of things.
Yes. Other than that, I don't think I have much else. Just kind of starting to get ready for legislative session, as you all are aware from yesterday. See how that goes.
Is there any questions or anything? All right, let's go ahead and we'll move to the next item on the agenda. We have a UDAP product cost analysis. Right back to you.
All right, you guys are going to share that up there. And again, full disclosure that I got told I was doing this like this morning. And so I really haven't really looked at it. So we'll all be seeing it pretty much first time as I read through it. So I'm sure that the folks in the Department of Health and Human Services will be able to kind of help with some of the questions if needed to. But again, yes, this is the medical cannabis price analysis. If you could just, thank you. Was the board asked us to take a look at the average price and weights of cannabis products, pretty much from almost the beginning of the program to the current date. So we went back to 2021. I think these charts show a pretty good idea that we've seen that the price per gram of THC in those couple of years has continually dropped. Thank you for catching up with that. So, which is a good thing, right? That's what we obviously expected, and we've seen actually what I think we can say is a pretty good drop in that price, especially looking at the amount of patients that we have and the amount of production that's been going on. That we're seeing some good things there. If you don't mind going to the next one, thank you. Just some wording on that. The price per gram of THC has decreased, as we saw above, and the price per gram of THC is, as I mentioned here, is a less useful measure for the gummies due to their higher likelihood of having more diverse cannabinoid profiles there. So it does kind of skew the gummy prices a little bit. But again, overall, I think we can say that the prices have gone down over time. Another graph here, as far as average price per item, as you can see, Gummies stayed pretty close. It kind of goes up and down based on the year, but has not really moved that far. Flour, we've seen a little bit of an increase in 2024. And it looks like that may be kind of the norm right now for the past couple of years. Then as you've seen with cartridge there, we had a pretty decent decrease between 2021 and 2023 with now a slight increase on 2024. So. Just some more information here as far as the average weight of products here. You can see that that's gone up in some cases significantly, especially on the flour side, as well as the cartridges. Gummies being what they are still, and also leads a little bit to that same amount of pricing happening there. But as you can see, everything looks to be getting better from prices and to average weight for the patients overall. It's relative, obviously, as we all know. We talk a lot of times about the black market in other states there, but as far as we're just looking at Utah, we're seeing some good trends in that aspect. Next, thank you. Just some key points here that we've already talked about. Cartridges and flour, price per items for cartridges has gone down, it's gone up for flour, and as I mentioned earlier, remained fairly stable for gummies. The weights have gone up for all these product types. And then again, the average item sold in 24 is around twice the way that it was in 2021. And then, like I said, for the most part, we've seen a lower cost in those as well. So fairly good thing to look at. I will open it up for questions if you guys have any. Maybe Rich can help, but.
So I'll kind of start off just for, so I reached out for some clarification on this. And then, I mean, Rich, if you want to, I mean, when you're looking into it, do you want to kind of, my understanding is when we're looking at the average weight per item, it's not the actual package weight, it's the total THC. So if you want to pull up that slide again, the average weight per item.
Yeah, I think that was one of the things.
Yeah.
There's vernacular being used in this that is not the way patients think of it, or producers think of it, right? And really the way patients think of it when they come to our store is they are thinking, how many milligrams of THC can I get for my dollar, right? And really, when you break it down even further, how many doses of THC, or other cannabinoids can I get for my dollar? So that's why I want to talk to you about, on a per milligram basis. And that's how patients are shopping, right? Very rarely does someone come in and say, what can I get a gram of THC for, right? Because no one is consuming, right? Outside of flour, even flour, that's not 1 gram of flour is not 1 gram of THC, right?
Yeah.
So I think that's one of the things that we saw, and I think just some of the vernacular is just not, like when we talk about weight, people are talking about packaged weight, not weight in terms of how many grams or milligrams of THC am I getting. And then also I think it's useful to make sure people understand that really what you're seeing here is as the program has grown in scale, you've seen offerings that offer more either THC on a per milligram basis or more weight, whether from a THC perspective or from just a general perspective, right? We now have ounces of flour available. In the early days, Dragonfly, when they were the first one open, you could get 2 jars. So all you could get 2 8s was the maximum you could get, and then they would turn it away. So I think that part needs to be factored in. And then I think one thing I will say, just generally, is now maybe once we kind of know what the patient is paying at the counter, we now need to start to understand what informs cost, right? From a basic economic standpoint, right? So then we can look at to say, okay, if we want to reduce cost, what are some things we can do from a regulatory perspective or from a legislative perspective to promote those things, right? Because you look at a state like Arkansas, right? Arkansas has had a medical program about as long as Utah, right? But they have double the amount of patients. We would love to know why. Now, some of that might be because they're not surrounded by other rec states. Maybe they don't have as robust an illicit market as we do, since we've got I-15 and I-80. So I'm hopeful this is the beginning point for a much further analysis into cost, right? Because I think you can look at these numbers one way or another and say, oh, hey, we're really coming down, or you could look at one of them and be like, oh, well, flour's gone up. I think that's a part of the equation. So I'm hopeful this is the start of a much further analysis into cost.
And when I dug into this and looked at it and got that information, I mean, it is positive to note for those that kind of don't understand what I'm talking about on here, when it says average weight is for gummies, for example. I mean, the average purchase item back in 2021 had 130 milligrams of THC in it. Right, whereas if you look at the far right number, this now is averaging 300 milligrams is what they're getting. Right, so for gummies, this report, if you understand it that way, that makes sense. Vape cartridges, it's hard to differentiate between the size. I know in 2021, a lot of the vape cartridges were half grams. So that's why you're seeing such a smaller number of 0.33 grams of THC. Whereas if you're looking at today, a majority of them are higher amounts, and then we're actually seeing out to 2 gram sales. So it's adding to that. Flour, if we go back to the pricing on there, a lot that can account for pricing there is not necessarily, this is not an 8, people think in 8s when they think on pricing. We're seeing a lot higher volume in sales and flour. Not the traditional 8s, it's now, there are people doing 5 grams as the standard. There are some that are doing half ounces, they're doing full ounces, and so that takes into account on the per item for the pricing. And so although we did see an increase in price, that's where I would love to see on future iterations of this report for our board is it possible to get a breakdown that shows, you know what, if 62% of all flour sales were 8s, or whatever the size, we get a package size. Now, I know there may be limitations based on the reporting that we have, hopefully going into the new ICS. And through that, it will allow us to have a little more transparency in the sales information that we can get to us. But getting the breakdown helps. Gummies is also one that is difficult because because there are many producers out there that are making gummies that are high in ratio ones. Meaning it's a 1 to 10 or a 1 to 20, so THC to another cannabinoid. If this is looking at the price per THC, of course that number is going to be quite large. I mean, I can speak to some of our own products, is that we sell items that have 0.01 THC when it comes to our CBD gummies. And so, I mean, if you did that in the THC comparison, you're talking that turns a retail item that's $30 to a $3,000 item. Which can, if you're trying to adjust that towards the THC percentage. So I think for us, I appreciate the information, Cody. I think for me, I understood when we were in here. I just think if we can get a little more specifics to kind of help understand what's driving that cost, especially as we get into the next items. I think that will definitely help. I mean, I'll speak for myself, it'll help me kind of understand where we're at as a market. I don't know if anyone else has or any comments on it.
I'll just say that and maybe open up to either you two on the board or to anybody else there, but could you guys speak, and this is me and all people throwing you guys maybe bone on that, but to me, it also seems like we're seeing quality.
No,
and the next numbers show that.
I'm not sure, I mean, I think what they show is they show that patients again are shopping on a per milligram basis, right? The reason ounces are popular is they are on average getting more milligrams for their buck, right? As you scale up in size. But I also think too, that you'd be crazy to think that the quality day one of the program is what the quality is now. And also, this is another thing I think we need to factor in, is there are live products being produced, right? You have live resin products, you have rosin products being produced. And those could be more costly products to produce, but they also take the quality to a higher level, right? You could have a distillate product that has a single cannabinoid in it that's mixed with botanical terpenes that don't even come from the plant, right? You can go all the way up to a live rosin product, right? That's produced from fresh rosin, that is a full spectrum product that provides a full entourage effect for patients. So I think that's one thing that has to be factored in, is that over time, the quality of products and the breadth of those products has increased as well. So that probably is factoring in with the price, because when you look at that kind of average weight, as the weight's gone up, the prices have kind of stayed the same. You would think that that you kind of see the inverse, right, that would go down. But I think the reason some of the prices probably hold steady or steadier is because you've seen a bunch of different form factors, not just like, a gummy versus a vape in the market, but even within those, you have various different things going all the way from that distillate with botanical terpenes, all the way up to those live products that are full spectrum. So I think that probably should be captured as well, and that might be part of what you do when you start to break the analysis down further. Is you do on a kind of overall category basis, and then subcategories within that as well, divisions.
No, I didn't, but he also opened it up to people back here.
So, we'll give, is there any other comments from the board at all for Mr. James? Or anyone?
I would just say make it more understandable for patients, so from a user standpoint, that it's.
Understand.
And I think what would, one suggestion is like, board members can say, we want this data set specifically, like say exactly what you want. And then we can take a look and see if we can put that together, or as a patient advocate, this is what patients, literally, this is exactly what they want. And then we can work with ag on making sure that we get as close to that as we can, if it's possible. Yeah.
I think, you know, as a board, I think it would be good for us to kind of put our heads together and think, what information would we like to see on this? I mean, this isn't a monthly, like, let's get this report every month. This is more of an annual one with an annual update. I think it would be good, or semi-annual, kind of see where things are trending. You do too many reports and you just get lost in the numbers. You do them too far apart and you can't see the ebbs and flows. And so we got to find a good balance in there, but we'll go ahead and kind of go through. We do have people who have signed up for some public comment. I'll open up first to those here in the room. And then if there's anyone online, we'll give them an opportunity as well. So if anyone wants to come up. Just say your name and affiliation.
Hi, everyone. Nareth with Dragonfly. Thank you guys for putting together this report. I think despite some of the inconsistencies in vernacular that's being used, it paints a very clear picture that since the inception of the program, the cost of THC has gone down. And I think that shows that among the operators, despite everything stacked against us, you know, going through COVID, going through recession, going through consumer price index from 2020 to 2024 now has increased 10+ percentage points. The cost of gas, milk, eggs, grocery, everything has gone up, but cannabis has gone down. So I hope this really paints a clear picture for us as stakeholders in this industry of what's really happening out there and what the real narratives out there. Plenty of opinions, plenty of things can go around of where's money going, where is this happening? But this data clearly points out what has actually happened with the price of THC per milligram. So that gives us opportunities to, again, look in other areas where we haven't looked at yet to see where is cost being driven, right? There's operational costs. We obviously know there are legislative and regulatory costs. We know Section 280E, and I still feel like that's not widely understood by most people out there on how impactful it is for operators to work under a Section 280E. It's huge. It is huge. It is one of the biggest costs that most of us don't have a lot of control of over in this room. But there are decisions and rules that we can make to help make that a little bit more favorable so operators can pass those costs and pass those savings on to the patients. Thank you.
Thank you.
Yeah, that was especially for our cooperators, right? Because once you get to the retail side of things, I mean, short of it is most of the reductions. It's the Sam stated 70% on that's why most cannabis companies are not profitable.
Only 25% of cannabis companies in the world are actually profitable.
All right.
So yeah, I want to just say that I actually, oh yeah, Alex Orge with Wholesome Co. Cannabis. I signed the thing. I don't know where around, but I think the message here is that we're looking at data, and I think that's important. We need to refine the data we're looking at, and it acknowledges in the report that there's inaccuracies in the data, and you're pulling it out of MJ Freeway. I know what those inaccuracies are. They do a very poor job of providing categories and subcategories. So when you look at like item, really, you can only pull it into like a vape cart, right? Even to get the size of the vape cart is very challenging. To do this study accurately, you'd have to get a data scientist involved. You'd have to, you'd have to pay somebody that has a data science degree to go in and fix all the data at its in an Excel file or whatever it's going to be. You'd have to get someone to first fix the data, because coming out of MJ Freeway, we deal with that data as well. We have a data scientist on staff that has to go through and correct everything. I can't pull any accurate data to make decisions by relying on the Domo instances out of MJ Freeway. So I think that would be the first thing. To get usable data, we're going to have to we're going to have to pay a data scientist from probably the University of Utah to do this. And then when I look at some of and I only have 30 seconds left, but there's also these graph lines on top of it. And when you look at like the cartridge, and this supports the idea that the data is inaccurate, saying that a gram per cartridge of THC is $192. That is probably triple the actual price, because there's data inaccuracies in here. So we're going to need to really take a look at this and fix and determine what we want. And I'll share some data, or I'll share some examples of studies that I think would be helpful. And I can just email those to whoever, maybe the board, that I think would actually be helpful to provide policy decisions.
Thank you.
Hi, Bijan with Beehive. I don't want to beat the same drum, but I echo the similar comments, mostly within delineation within the graphs. So like to JD's point, start of the program, which is distillate. Now we'll have half gram and full gram rosin products. Half gram of rosin is about $60. And then a half gram of distillate is going to be 30. So those could skew within that category, some discrepancies. So I think delineating within gummies the category of ratio products as well, so that we're not skewing just the price for THC. Granted, minor cannabinoids are much cheaper than THC, but I think if we categorize ratio products, distillate products, and then maybe others, resins or rosins or live products like JD mentioned, would help give a more holistic view of what we're actually comparing apples to apples on. Also reiterating just the price per gram in flour. Most people purchase based on a price per gram on flour. At the start of the program, there was only 3.5 grams. Now I've seen 1 gram, 3.5, 5 gram, 14, and 28. So looking at a price per unit, obviously that has gone up because there weren't ounces at the beginning of the program. So if we tweak the data a little bit, I think it would give a more holistic viewpoint, but it does, I think we're all on the same page that the price of THC is going down naturally with the supply chain that matures, price of things come down. But we are up against a lot of fixed costs like taxes and license fees, which make patients determine, do I purchase from the illicit market or not? So I think if we give, this information is great for operators, but I think patients also will want to look at it when they make their purchasing decisions. Do I go to Mesquite in a recreational market, or do I maintain within our medical program?
Thanks, Bijan. Do we have anyone raise hands online? See. Just one kind of just clarifying from my understanding with the report on that pricing. I mean, I know it was brought up that in 2021 a vape cart was $192. Part of that is just adjusting that price to get one. If it was 100% THC, it would have cost $192.
No, it wouldn't.
Well, majority of the carts were half grams at that point in time.
We'll talk after. I'll explain.
Okay. Well, I mean, again, for my that's how the numbers were gathered, right? They were looking at the potency percentage because that's what they had to adjust it upwards. But again, I think for us, we all clearly understand that there needs to be a little bit more transparency in the numbers we're getting and where it's breaking down. I appreciate the public comment on there. I mean, I know a lot of us took notes on what was said and what we'd like to see. We'll definitely make recommendations to Department of Agriculture to include some of these changes in there for upcoming reports when we get this cost analysis done. So is there anything else anyone would like to add? If not,
I think one thing we can look forward to in the future is having with our new inventory control system hub with Salesforce. I think we can be able to be empowered with our data a little bit better and be able to break it down into the specific categories. That's, I think, one thing that we plan on doing. So it's a challenge now, but we'll be able to break it out with different weights in the future.
Only thing I can say, just the last thing is we do so much as operators, right? Appreciate the department's willingness to use data and make data-driven decisions, right? Because data is objective, right? So it's not the subjective, oh, hey, I feel this way, hey, I feel this way. As my old football coach used to say in college, the video camera doesn't lie, right? And the videotape never lied when we watch film together. So I really appreciate the fact that we're going to come together on this data and make data-driven, decisions and not just, this type of decisions. So really appreciate it.
Okay, all right, we will go ahead and move on to the next agenda item, which we have is patient cost. So, all right, Des, you ready? And Nanette?
Yes, I think we're just going to tag team this. Can everybody hear me okay?
And we're going to turn the volume down a little bit in our room.
I can hear you too well.
Am I really loud? I like that. That's actually really exciting for me. So, one thing that, I think that this was all a good segue into what I'm going to say. We've been working on patient cost for a while now, just trying to get to the bottom of why. And like you saw with this with that last presentation, it's very specific and it can go a lot of different ways. So, what we were finding is that we would start looking at one specific thing that was possibly driving up cost, and next thing you know, we're down a rabbit hole and we're really struggling. One thing that we found that we couldn't do is prove that we were right. Like if we found something that was raising cost, proving that we were actually right, we just didn't have the ability to do that. Started getting kind of nervous, and then we've talked to almost all of industry, a lot of patients, and I think what we kind of have landed on, and I'm hoping that this will just kind of produce a really robust discussion today, is looking at having a third party do a study. So what we would do is, as the board, we would advise the lawmakers to commission a study. So, and what we need to decide is what we want to have studied. If that is something that we want to do, if that's something we want to look into, and B, what would we want to ask of them? So, there's so much. So if you start looking at pricing, we have to understand that there's overhead cost is at the pharmacies. There's a different cost for processing. There's different costs for fees. Their insurance is a lot more. They have to pay, I think it was like $50,000 a year just for banking, just to have a bank open because they deal in cannabis. There's all these extra fees that, and every time I would have a conversation, somebody would say something else, like compliance officers or something that was just, it all adds all this cost. So, yeah, so basically what we were thinking is just, what about us commissioning a study? Another thing that I wanted to bring up is there are some things that we know we could do that we voted on last year, like the 280E tax credit idea. They tried to pass that last year and the budget just wasn't there. So, maybe we, again, just go forward and say, let's ask for this 280E comparable credit, and see if they'll run another bill. And if they will, then that would give us the opportunity to, I think they said it's like 40%, it's a 40% increase. So that savings, I'm assuming, would be passed on to patients, and their overhead costs would go down. So I assume that cost would go on to patients. So Nanette probably has a million things to add, but really just, I would like to open it up just for a good discussion on what kind of things do we want to study? Like, do we want to look at the program cost, like market factors, the just like the structure and the efficiency, how hard it is to get a card, all of these things add cost. And then looking at like financial audits, but looking at like if one way we're thinking to do it is you take a $50 1 gram vape cart and you break it down into areas of expenses, like how much of that cart would go to regulatory costs, cost to cultivate the biomass, cost of processing, cost of packaging, cost of labor, cost of transportation and overhead, and then retailer costs, advertisement, labor, regulatory costs, all of that, like really understanding why their price point is what it is, and then deciding, then once we have a professional that has a degree to do this, and that's not just guessing, then start looking at where we could reduce some of that cost. If there's anything we could do, if not, then we know that. But then also looking at other states, looking at what other medical only states are doing, what are our price comparisons to those. I think, we have Trevor who could probably help us with that. And then maybe even looking at the cost of, going out of state or using the hemp market, just comparables to those. So those are some ideas that I have. I know you guys are all from different areas, and I think we could kind of nail down a good way of creating a study or commissioning a study that would kind of get these different areas and hopefully get a really good picture of what the program is like. And so we can start understanding the cost, so then we can understand how to drive it down.
Well, to add to Des, I just think that we know that we are missing a bunch of patients. We know patients are using on the black market or they're leaving out of state, but do we know why? And I think this would really help us understand why they're leaving. We don't have any data on that. Hopefully, that would be one part. But I think a third-party study would also help bolster patients' trust in the program. If we have a third party to say, hey, this is why, this is what they're doing, and you have credibility there. That's really fun.
That's, yeah, I know, and I'll kind of step in. So when I was talking with Des about this thing, she'd been trying to work for months on trying to get participation from within the industry and from others. And it's been difficult to kind of narrow down exact costs on what patients are actually paying and what she was looking to get done. And so I think as a board, we recommend, let's discuss it open between ourselves and what type of information would we like to get. Why is it that when it comes to the patient cost side of things, what's going into that? And I think a lot of times we hear, we're going to hear very common things. It's going to be, there is an undue burden on tax when it comes and a tax credit or a tax change with 280E should make a substantial impact towards the bottom line for retail operations. Now, what that looks like in the near interim future, especially with the potential rescheduling, we don't know. I mean, as of today, I know we'll find out at a future date when that is announced. But I think for the cost for patients today is there's a huge thing, there's a huge side in there. And kind of, I do have a question, and hopefully Trevor, the answer is, I know you did a study for the patients that had left and did not renew their card. Can you remind me and hopefully the board as well, what was the number one reason why they didn't renew?
So we had the general reasons, which I believe there were 6, and then the 7th was other they could choose from. Out of those general reasons, I believe the top was that they could not afford their renewal with their medical provider. But when we broke it down into more detailed sections, the top was pharmacy too expensive. But I can double check that right now, and I'm happy to put that on the screen.
Yeah,
That's that too.
yeah, that was it. Yeah. Yeah. So I think for us, it's if we know that patients, they feel their biggest cost is entry into the market. And then the second one is then staying in the market, right? Because those are the two costs you have, right, as a patient. And again, it's kind of a biased report. And the reason I say that is because these are patients left. Right? We didn't reach out to current patients. Most of the patients, I'm sure if you ask them, you're going to get a large subset that are happy with the prices they're paying. A lot of patients from what I talk with people, they're happy to pay a premium because they know it's state tested and approved. The quality of it is better than anything that they've been able to receive anywhere else, and it's trusted. And so I think and then they're working with a pharmacist. That pharmacist, for most, they care about their patients, and they're going to care for the medication we're getting.
Well, that was one of the
Yeah.
analysis that you'd have provided,
Yes.
right, through, some of that is those people said that on average, they were happy to pay more to purchase from a legal source, and generally probably from by those reasons you just gave, so that's been more outdated, not just anecdotal.
Oh, yeah. Yeah, no, and that's what I was gonna bring up. So Trevor did bring up the report. The third one on here is out-of-state dispensary was cheaper. So we're gonna go back to cost. So number one was the providers too expensive, really almost hand in hand on numbers here, within 10%, because pharmacy was expensive. And then it dropped down quite a bit to where it's they can get either cheaper out of state or cheaper from a personal source. So
well, I think if we do what we're talking about here, what Des talked about, and I talk about a holistic kind of study on pricing and cost. Not only will I think it help to inform, patients or people considering becoming in the program or people leaving the program, what goes into the cost of their medicine, but it also then gives us the ability as producers to have honest conversations about why we will never be able to match certainly the black market, right, the illicit market. They have no regulatory costs. Cody James does not regulate any of them, right? UDAP doesn't regulate any of them. DHHS doesn't regulate them. Jimmy might regulate some of them, but you know what I mean? So it gives us the ability to talk about that, but then it also allows you to have the conversation about the difference between an adult use market that can serve any person over the age of 21, right? Versus a market like ours where you have to be qualified to become a patient, right? So I think it'll aid the discussion in both directions in helping inform patients and being able to have a good discussion between operators and patients, but then also having the discussion of why it is so important that we continue to improve access to medical cannabis. Because every time we enact a regulation that creates another hoop for operators to jump through or patients to jump through, most patients are not going to quit using cannabis. I hear quite often people say, well, maybe they just didn't think it was right for them. That is very rarely the case. Usually they find a different source to get it from. And if we want to promote criminals and their bottom line, or not as bad, but equally concerning, somewhat equally concerning, is promoting the economies of other states, right? You have folks from Nevada who are right on the, or Colorado, these border towns, right? And some of them are even advertising inside the state of Utah. And if you go to their parking lots, they are not filled with Colorado license plates and Nevada license plates, they're filled with Utah, right? So that I think will help us further discussion on why it's so important that the legislative priorities we're putting forward as a group, hopefully collectively, is to try to increase patient access. Because I, again, talk about a state like Arkansas, double the patient population, then substantially more patients than we have here.
No, we have about 90,000.
Yeah.
And they have about 100,000.
Okay, different than the numbers, so the numbers.
I'm just saying double what we do.
Revenue, yeah, revenue, that's what I meant to say, double the revenue, right? So why is that the case? I think just the thing to say is we don't want to keep losing patients to the illicit market and to markets of other states, right? And so I think this will help us, this will inform us as to what the correct legislative priority should be.
Is there anyone else from the board or anything in the comments? Yeah, I think the idea of a study that we can specifically target towards patients and understanding why costs are there, an independent one. I mean, anytime you do an independent study, it's better as long as the questions that they're asking are probably enough to where we're getting. I mean, we don't want you don't do a survey to get answers, right? You do a survey to find. You need to find out everything. And it may not be the survey we want. We may do a survey and say, hey, patients are okay with the costs. And so at that point, it's like, okay, well, what's our next step? And so you have to be able to accept the outcome, but I think for the state of the industry is based off the last couple of topics, we've seen prices haven't gone down. You know, for some, it may not be as aggressive as what they would like to see. But at the end of the day, the access to quality medication is better than it has been in years prior. And so for us going forward, it's how can we maintain that patient level and really how can we grow? And I think I remember this kind of goes back to the cost and kind of JD brought it up is we talked about what can the Department of Health and Human Services do as far as education? What can we do to educate and as a public safety thing? I mean, I'll kind of, and I said it back then, I'll say it today, and I would love to see billboards or information out there from the Department of Health and Human Services saying, hey, we have medical cannabis and it's quality tested and just informing the public. Because there's still today, I mean, it's almost, we've been in the industry for 5 years growing now, and it's insane. I get people who still don't know that medical cannabis is the thing. They find out that I do it and they're like, really? That's not illegal? I'm like, no, it's been I don't know where you were for Prop 2, but it's been here. And so I think that's really what is the key is educating the public. I don't think it's necessarily something that's gonna push people either direction. It's just letting them know, you know, you have other options. You don't have to travel out of state. You don't have to see your plug. And I know from in talking with people who have done billboards, there is an uptick in traffic towards websites. There's an uptick in it, and that's all education. And if we can get them to the state website, where the website is pretty good on educating patients, I think that's a good way to get the message out that, hey, it's here. But I don't know, Rich, what do you feel on that?
At this point, I know that the industry has billboards. And they say medical cannabis delivered to you, to your door, right? And there's a lot of messaging that the private market has done. And I feel like that reminds the public about the fact that there is a legal medical cannabis program that sells state legal cannabis that's safer than.
I think if it was state, it would be a lot more assuring to us. We would go, oh, this is trustable, this is legal, this is.
Sure. Yeah, and I think you can understand it's a new space where we've got what in large part, in most cases, is experimental. And so the state needs to be careful about how we approach that, right? I think that's something that we can investigate further and get back to you on. I know at the beginning of this meeting, I shared how the University of Utah is going to be publishing these 3 videos that educate patients about how to consult with their medical provider and their pharmacist about medical cannabis and how to do it responsibly. And we can engage with you about other ideas about how to do it in appropriate ways. There's, I think, some additional dialogue we can have about that topic. Other states have done some things that I think may be appropriate in Utah, and they've also done some things that would not likely be appropriate in Utah. And so,
What things do you think would be appropriate?
I don't think now is the right time to go through those, but I do know that there's some states that they do a public education campaign and they'll I think I'm just thinking of some examples of how they've done it, and one is that they've I don't know if like outright advertising as it being a evidence-based alternative to opiates is the best way to approach it.
What if they had the science that backs that? What if they build?
I think the science is mixed about it. I don't think I think you agree that it's mixed.
Yeah, I'm not disagreeing.
Okay.
I just think too, it would be helpful to know like what position the department wants to approach it from right? You know what I mean? Just like when you go to a substance abuse conference, what position are you approaching cannabis from the substance abuse conference, right? It's just informative for us to know, so then we can help provide maybe some ideas to you all, right? As to what's the best way to approach it, but I agree with Nanette that when a producer says it, right, and puts it up on a billboard, right? I think a lot of people assume that's very, very certain. So I don't think we'd ever ask you all, right, or recommend to you all that you say something that you don't feel comfortable with, and I know you guys won't, right? But I do think that while some of the data is mixed, the data becomes more and more promising, by the day as it's studied. I mean, I subscribe to a host of cannabis newsletters, right? And studies that come out, the majority of the studies continuing to come out about cannabis are finding what we've all found out anecdotally using it over these last however many years. As cannabis becomes more legal and more widely studied, I think one of the other things too, the data seems to follow the anecdotal stories. Not always, right? We always have to caution. I tell people cannabis is not a panacea, but I just think that if we want this program to grow and we want this program to be sustainable, and we don't want to get to a place where the citizens of Utah start to push really hard for a ballot initiative for adult use, because I know that's not what the state wants. We have to help them understand why the medical cannabis program is good, why they should be a part of it, and if nothing else, that it's just an option for them, right? You don't have to say, hey, this could be an alternative to opioids or whatever. Just helping people to understand it's an option and seeing state support for that and the agencies of the state trying to put that information out there, I think it carries a little more credibility. But I get you have to be careful what you say.
Right. It's complicated. It's still federally illegal. I think some science is still mixed about it. There are some studies that I think do guide patients, and it guides them to some of the benefits, but also to some of the harm and how it needs to be used responsibly. So, yeah.
If I may, I'm happy to remind the board back in February, you had on the agenda public education on cannabis, where I pulled some examples from adult use and medical only states. So I'm happy to recirculate that memo in this conversation offline if that helps remind us what we've seen, some examples, and I'm looking here at the minutes, some things you all discussed as a group, including the fact that the University of Utah Center for Medical Cannabis Research had a representative here who said that they had allocated $50,000 in the previous fiscal year for public education.
Is that for those videos?
I think that's a big part of this.
Yeah.
But if it's helpful to kind of reevaluate some maybe additional public education campaigns, we can see some from some medical only states or medical programs in adult use states. I'm happy to provide more of that and see if there's updated examples.
Yeah, good. Could add something just a little bit, and the Department of Agriculture definitely understands that a lot of what's going to be done outdoor to the public and the patients is DHHS. So, but I would just say that the Department of Agriculture, based on what we've talked about internally, and I think what Dr. Forsythe has said at these meetings, was that we would be really okay with putting information about the quality assurance portions of it, that there is that safeness and that those products being used. That thing, right, as far as that goes, and it's not necessarily our spot to do that. That's just the plain regulators. But we do feel that that's definitely a selling point that we feel for this industry and for this program is, as I think you said earlier, Matt, that we are doing, better than the black market is making sure products safe.
Just knowing where Utah's at, we're at the forefront of the medical side of things. We're looked to as a program that's, obviously as a producer, there's times I feel the regulation's a little extreme, but I understand that as a safety basis for patients, they stand by their testing and they know what's in it. And so, that's why I appreciate the lab and what they've done. That really all I was looking for I'm not looking for something saying, hey, let's stop using your prescription pills and come to cannabis, right? As a billboard, I'm saying, what was the information? Did you know we have state tested cannabis and at our website? Something very simple that can just inform the public about it and report it.
Yeah, sorry.
Oh,
Interrupt. No, I would just say, I think in short, just, to continue what Rich was saying, is that we recognize that there's a need for education. We are just very early in the conversation of what that might look like. taking into account what our statutory authority is and what our expectations are. So look, just again, we're open to those conversations. We recognize a need. And we need to do it in a way that aligns with the work we do. So yeah, just, I think that's the short of it. And we want to continue those conversations, and we are internally having those conversations.
Yeah, I think it'd be good to see, once you guys kind of define the roadmap on what you feel that education is gonna look like besides these 3 videos. Is maybe present that in one of your updates in a future meeting, Rich.
Yeah.
So that way we can kind of see what we're looking for. Yeah.
I mean, a billboard that says we have it, it's tested, COAs, things like that. We give and they public trust to know that.
Yeah, and what we've done in the meantime is we've also contracted with a medical provider to do trainings directly to other medical providers in the state. We know that based on some research that's been done, that patients trust their medical providers for information and their pharmacists for information. And so we want to invest resources in educating them rather than getting it directly from the state. It can be helpful to get it from a medical provider.
I don't think it's for education. I think it's just, hey, did you know when you say you have conversations with people that don't understand that it's illegal to do? I think that would be what we're trying to say is we're missing out on the market of patients that we don't have access to. And it's probably a reason why. Maybe that would help.
Sure. Yeah, and if I don't mean to interrupt you, but there's also another thing, like, because we can sit around this table and say all these things out there, but really what it comes down to, even with Shannon here, and that there's people, well, all of us too, that are gonna say some things as well, right? So maybe it comes down to the governor doesn't want to say it. I'm not saying that's the case, I'm just saying that, right? We can say some things here, and I think everybody said what they really like what Nanette said, and that would be our standpoint too, is just to put that out there. If we're gonna put something out there, as far as testing and safety, but yeah, Shannon's got bosses, Brandon's got bosses, they've got bosses.
Yeah, no, I understand. I just look at this is a health and safety thing. I mean, even the analysis and all the things we've gotten back from these independent studies that have been done just show that, patients still want to state and still buy from a third-party source within the state illegally.
Well, I think that's probably, there's things we disagree on. I'm hopeful there are 2 things we can agree on. We don't want patients being criminals, right? And we don't want people supporting the economies of other states when we keep that money right here in Utah. But I think as long as we feel good about those things, I know, I'm sure there's some things you want to go to Wyoming or other places.
I was gonna, this is a public meeting, so I won't say it, and I won't say it. So,
But I think generally when it comes to cannabis, and I think as long as we feel those 2 things, we can find a way to, the right way to get there, right? Because certainly that's not what we see, right? We want to support criminal activity, and as much as we want to go to Las Vegas and gamble a little bit, I don't think people want Las Vegas to buy all their their cannabis, right? So we want to keep those Utah dollars here and keep Utahns, in the program.
I appreciated the discussion there. If there's anything else from the board, if not, and we do have a couple people that have signed up for some public comment. We would open up some time to those here in the room, and then if there's any online that'd like to, they can raise their hand.
Bijan with Beehive again. Thank you, Shannon, for providing some insight into your guys' mindset on the education piece. This was more of a cost per patient, and I think we kind of sidetracked a little bit into kind of an education piece. So I'm just going to bring it back to the cost stuff for the patients first, and then move toward education. As a private operator, we don't get to deduct any of our advertising expenses. So these billboards that we put up are relatively expensive, and they don't necessarily convert into sales. So for us to do the public education, when the state maybe has resources they could tap into for that, I would nudge the state to say, rather than put that onus on private operators, I think the education could come from the state or department. The cost per patients entering the program should be factored, as well as maintaining the program. So renewals plus first time entrance when we do our pricing analysis. So not just looking at the price for patients, but is there a way we can factor in their costs to enter the program and maintain the program in their spend. Because we're looking at producers and retailers and not just the QMPs that are also part of the closed loop system. One thing I do want to shed light on, and thank you for listening, is in February, there were 995 new patients. 252 of those did not make any purchases, and 300 only made one purchase. That's 18% of our total population of active card users that have never made a purchase or have only made one purchase. So I think that is a demographic that we should survey. My initial take is they're going through the hoops to protect themselves, but are not actively maintaining the program. So that's almost 20% of activated cardholders that if we have the resources to survey them and inquire what is their intent, I think that gives us a more holistic view. So we can look at, to reiterate, the cost of entering the program, the cost of renewing your license to stay in the program, and then looking at how and why are some people just entering the program and not actively making purchases in our program.
Thank you. Is there anyone else?
Yeah.
Yes.
Alex Ward with Wholesome Co. So just to kind of continue on some of the things that Bijan was saying, we've recognized a little bit of a slowing in the program. We've continued to see growth. We've seen, nearly 90,000 patients. But when you look at active customers, it's about 49,000 a month. And like Bijan alluded to, we really do have a potential demand problem, and how that impacts ourselves at the production side is when we're looking at the market to see, okay, how much packaging do I need to order? I'm going to need to order less packaging than anticipated. Whenever we're growing, I know that people in the program have started growing less, just looking at where the market is headed with the lack of growth that we've seen in recent years. The economies of scales are not being able to be taken advantage of, not based on our patient count. To your point, Rich, like we're 15,000 patients less than Arkansas, but yet the revenue we're seeing each month is about half of what we see in Arkansas. The reality is we live in a state that's bordered by a lot of adult use programs, and I would like to see a goal, a stated goal that we actively are trying to reduce illicit cannabis sales in our state. I think the UDAF report that they commissioned through the Medical Cannabis Policy Group was very helpful. We found a lot of information that 60% of the products being used in our state are coming not from the medical cannabis program. That's 1.5 times our current market, which would put it annually at about $225 million a year. So being able to capture this demand is going to lower prices through basic economic principles of supply and demand.
Now, the Dragonfly, to kind of piggyback on some of the comments that have been made earlier in regards to kind of patient attrition and new patients. We track this data as well, and what we see in our data is 1 out of every 4 new cardholders never purchase, right? And then you ask the question, well, why? Why would somebody go through hoops of getting a card to never buy anything in the state? Well, the answer is they want to be legal, right? Nobody wants to be a criminal. So they get their card thinking they're legal, thinking that if they buy products from other places, they're going to be fine, right? People aren't educated that is still outside of the law. So there's still a lack of awareness. And to address comments made in regards earlier about, okay, there's varying science over there. I think it depends on what side of the coin you're. If you're an operator, there is no doubt that cannabis is serving patients and helping them. We just wrapped up a study with a data analytics company that took EMR data, looked at the contraindications that patients were getting prescriptions for, right? And among the cohort of patients that were using opiates, benzos for pain medication, we reduced their opiate usage by 53%. Now, if you look at Department of Health data that shows opiates, the deaths related to opiates, 2019, there's a steep drop off of deaths related to that. In fact, between 2020 and now, we've seen a 37% reduction in opiate related deaths. Cannabis program started in 2019. You can say that's a coincidence. We know in the industry that is not a coincidence. Cannabis is saving lives. That's a public health epidemic here in the state of Utah that the Department of Health is responsible for. Not just reducing the opioid epidemic, but also reducing illicit drugs in the market. And we literally have a medicine that serves both the purposes, yet it doesn't seem that we're proud to own it, that we're proud of this program, that we actually believe in this program, because that's where they're there. I see billboard campaigns all over the place. Yeah, 10 more seconds.
Okay.
DHS spends money on HIV awareness programs, billboard campaigns all over the state. We spend money on social media awareness programs because we believe in those things. We believe in the data and the science, and we support those things. And I think that's where the challenge is, we know that there are people in this state that don't believe in cannabis, people in positions of power and people in positions of leadership that don't believe in it. And unfortunately, we all have jobs. We all have to follow what other people say and what other people in the state want. And we got to do those jobs. But that's the reality of the situation. Is I don't think there is an argument on whether cannabis is efficacious or not. This is not anything new.
Right.
We've been operating cannabis for a really, really long time, our entire civilization. Thank you, guys.
Thank you, Darren. Is there anyone online?
I don't see any hands. Oh,
There's a
wait,
hand. All right. Go ahead and give time to Blake. Blake, you have 2 minutes.
Can you hear me now?
Yep.
Excellent. Hey, thank you for allowing me to speak. I just want to point out, the state has spent money on things like campaigns like Gray Matters and so forth. And I have heard in this meeting alone the term good medicine used by not only people in industry, but also, representatives on the board and so forth. If that's the case, then we should recognize this as a medical product. There are some groups out there like the Mississippi Cannabis Research and Review Board that have been approved for $1.5 million to actually do studies with cannabis to start to demonstrate some of these things. The biggest thing that I think is really glaring is the UMA has never once got behind the cannabis program. We're expecting doctors to educate. We're expecting industry to pay for education. We're expecting all these things. I don't understand why, if this is a medical program, that the Utah Medical Association cannot actually support this. And so I would ask everyone there to help us. If we wanted the program to look a certain way, help us as in industry get there, and help us do that by getting the appropriate cardholders in this, stakeholders, to do that. Pricing, that's the whole point of this whole conversation. I've never been asked about my particular pricing. I have all my cogs. I can tell you what it costs to do everything. But yet, not all stakeholders in the industry are also consulted about all these various issues either. And I can tell you, industry is pretty unified on a lot of these things, but we can't seem to get a consensus for everybody else. Thank you for the time.
Thank you, Blake.
yes.
Okay. All right, if there's no further comment or anything, we'll bring it back to the board. Des, after hearing all that, is there anything, what direction are you wanting to take this patient cost?
So I guess I just kind of want to rein it back in a little bit and just say, like, my initial proposal here was to, propose that we ask the lawmakers to commission a study to look at probably like economic factors, judging by this conversation, and maybe just an entire program, looking at the entire program. And I don't know if that's something we want to try to vote on today, or if anybody wants what you guys are thinking. But I think, you can see how quickly this topic gets, it goes everywhere. Like, people have a lot of really strong opinions, and rightly so. And so, and one thing that Rich said earlier was kind of that this is a brand new program and we kind of just invented it as we went along, right? And I do think that alone, plus where all of these parts of the program that nobody can seem to get together on, I think that we should, really genuinely look at asking for a study of the economic factors and the program in general. And I should say third-party unbiased study. So that would be something that was paid for.
Is that your motion?
Sure. Yeah.
Second.
So we do have a motion that's been seconded. Abigail, were you able to get that at all? Or?
Yeah, what do you want
Just restate it.
formal motion to be?
Okay, propose a study that is commissioned by the legislator to look at the economic factors and the program, the medical cannabis program. Yeah. By, third party unbiased.
All right, do you want to just reread it before we take a vote?
Just a suggestion, if I could add, if there's any specific questions the board would want answered, it might help just to be a little more specific.
Yeah.
Because we're very general.
Holistic analysis, right, of that informs the cost and the pricing of products that we have, program, right? And I'm not sure that we would have to sit here probably the rest of the day to come up with all the questions to ask. So to me, it's a holistic price and cost analysis by an unbiased third party, right? Commissioned by the legislature, right? I think that's the thing. It's just looking at all factors, not just what we look at today, right? Pricing is coming down. Why is pricing coming down? And then also what informs the cost, right? So then it's a lot of what Des said is, to me, would be a great part of the study. Take a single product, right? Or take a single gram of THC or a single milligram, however you want to break it down, and determine from a holistic view, why does that gram, why does that product, why does that milligram cost what it does, right? And then you can factor in regulatory costs, you can factor in production costs, travel costs, all of those things. What does it cost to produce? But not just from hey, how much did it cost me to spit this widget out of the machine? What are all of the employees all baked in? What does that cost? And I think you will see for different providers, whether they're vertical or non-vertical, or even if they're non-vertical, or do they have a cultivation and a processing? I think you'll see some different things. To me, it's a holistic study into pricing and cost. And I would trust a third party to probably come up with good parameters and or lawmakers as they're commissioning and giving money to fund it to have further discussions, as part of the sort of bill to commission. So.
But in the end, it seems, why is the cost what it is?
Yep.
Right?
Yeah.
And, and then if they want to go any further, it would say what factors might, either general economic factors or factors that are germane to our industry or specific to cannabis. Do those, what do we need to factor in there that could cause price to go up or cause price to come down more? Because if the goal here is to continue to see pricing come down, whether naturally or accelerated, then we can start thinking of what sort of policy things do we need to do to get there. So to me, I think just the easy motion is just a holistic pricing and cost analysis, but at bottom it's what does it cost to produce a gram of cannabis, no pun intended, fully baked in.
Right. But that's economic factors or like a market analysis. Does that provide comparables to other markets and also like a program audit as far as like how people are getting onto the program, how our program in general is working? I
think those are two separate things. To me, how the program's working, some of it may overlap, right? Because you may have some costs of how you maintain compliance as an operator that probably feeds into how much a product costs on average. But whether the program itself is working or not, or the inner workings of the program, to understand it, I think is slightly different than what does the product cost. So I mean, it's your motion. To me, if you make it make it super broad and we can audit the entirety of the program, and this is just one piece we audit. Or you can request a study on this piece and or add a couple of pieces to it. I think, I'm just saying, to me, it's either super broad and we audit the entirety of the program, or you break it down and piecemeal it. And maybe there are two separate studies, or if you want to do them in one, I just don't see those as all matching entirely.
Agreed. I do think maybe we need to break it down into at least two.
And just another thought is one thing that maybe helped was finding an example of one in another state. And you think, we want it to be kind of like that one, right? And then there's like a clear idea of the goal. Because it's easy to get too broad and you lose some value, I think, if you make it too broad, like JD was saying, so.
And I think definitely, obviously, our place here isn't to give policy advice, and you may want to couch this in terms that you will follow the recommendations of whatever independent third party contractor you get to do this study, because one would think that would engage someone with a specialty in this, and that may be helpful. But ultimately, I think that's up to y'all as voting board members.
Seems like it's pretty long now.
You can do
It's gonna be my motion right now.
I've got recommend to lawmakers to commission a study of MCPAB medical cannabis, economic factors, and program as a whole by an unbiased third party. We want to read it up too.
That sounds to me like a program wide, the 30,000 foot view, as opposed to, like you were saying, drilling into the specificities of the cost to operators. So.
Well, yeah, and just, to me, I think that's more in line with what the agenda item is, right? A program-wide audit, is likely something that is far greater, right? It is going to take into consideration things that probably have nothing to do with pricing, right? May have more to do with access and things like that. So while there's some overlap, I think keeping it, more focused on, essentially, what does a gram of cannabis cost? You know what I mean? That's kind of more specific, but I think keeping it around more economics is more in line with what we're talking about here. A program-wide audit, while that may still be a good idea as well, I don't see those things as and I feel like a program-wide audit is going to be a harder sell in some ways and more expensive, although maybe necessary. But the economic study, if that's really what the big focus has been, we've heard from the government's working group, the cost is really what they're looking to study. This, I think, keeps it more, more narrow. But
If I just
Agreed.
change it and remove program as a whole, I just put like study of Utah medical cannabis economic factors by an unbiased third party. That sounds more.
I think you want to say factors impact cost and pricing
Yeah.
of products, something like that, just so they.
I mean, do you get a specific drill in? We do have product categories.
Well, I think
Do you drill into product categories?
I think we eventually, right? I think what we do is we make the recommendation, and then you and Des as the chair and the co-chair, right? As we want to push the actual legislation, meet with the lawmakers, involve other stakeholders, and then we can start to drill down into what we think the more specifics are needed, so then they can understand what the cost is. I think this is more of a general recommendation that's going to require a follow-up probably outside the board in line with the recommendation. That's all.
I'm good with what stated. Des, are you good with that?
I like that.
All right. If we got that written, let's go ahead and we'll do a roll call vote.
Nanette Perez. Yes. Candy Clark.
Yeah.
Desiree Hensky.
Yes.
Judy Higgs.
Yes.
Judy Lauritsen.
Yes.
And Matthew Beach.
Yes. Okay. Des, are we ready to move on to pricing transparency?
Representative Provo is not quite here yet. So would it be okay if we swapped and did the move first?
That works. We'll make an agenda change real quick. We're gonna do item number 8 before. So I was reached out to by many in the industry and people around the state on when our last meeting was canceled, and they would have liked to come to that meeting in order to discuss the following item. Really, there's not a memo, other than I just attached a letter that was received to the industry stakeholders. And so I'll kind of just read through that, so that way, and then we are posting it up on the screen as well. It was online, but so, back in October 2023, the Medical Cannabis Division of Utah Department of Agriculture and Food received a change request from the medical cannabis pharmacy to cannabis, now the forest, to relocate from Springville to Murray. The department is concerned with this request due to the potential impact of patients' access to their medicine. We held a public meeting to allow patients and other stakeholders to express their concerns. Following that meeting, it was clear that the pharmacy relocation would negatively impact patients in the area and could set a precedent for future moves impacting patients all over Utah. Unfortunately, the statutory language in Utah Code Chapter 4-41A at the time of the request did not give the department authority to deny the relocation. After some revisions to change the request, the department ultimately approved the relocation. To minimize the future impact on patients, the department requested the change be made to the statute to prevent pharmacies from moving outside of their regions. So these changes went into effect on May 2024, under the authority of the Utah Code Section 441A-1005. And then it says the department intends to issue another pharmacy license in Region 5, which includes Utah County, to provide patients in the area access to a broader variety of products. So just kind of open that up to the board. I do believe I recall many of the board, some were actually on that initial meeting. We did invite, when JD was chair, he sent out an invitation to all of those to attend that public meeting. And really, as the memo, this letter states, I mean, there was a lot of feedback and concern from patients at the time. At that point, it would kind of went quiet. Really, this letter was not received until I believe it was August 16th. And so there was no news until almost 10 months later, that the approval was actually given to the cannabis to relocate their pharmacy to a new location. So as you know, again, as it states in the memo, at this point, there's really not much that as a board we're able to do. I just wanted to open it up to public comment, and allow some of the people to kind of see. I think there could potentially, I do have some recommendation to the Department of Ag as far as moves. I mean, they can still happen within region. If a pharmacy does choose to change their area. And so I don't know if there's anyone else on the board before we open it up to public comment has any comments or anything they want to make.
Yeah, I did have one question. When was the move actually approved versus when were we notified? Were they contemporaneous with one another?
No, but I don't know if I have those exacts there. It took time.
So I guess the only follow-up question is was there a reason that the approval, and depending on how far apart the timing of the approval versus when stakeholders were notified, was there a reason why the notification might have come much later than the original approval?
That is a question that goes above my pay grade, so it'd have to go to someone above me. Okay, decisions.
See, Brandon.
Okay.
Yeah, just had a question there, and then I think the only other question I had is I know what you stated around statutory. Is that the only factor that could have been considered was, well, hey, there wasn't a prohibition in the pharmacy moving regions, but are there general considerations that could have been made by the department? And similar to what you guys did, when you initially kind of, from what we all understood, denied the move. What changed, I guess, between then, when you initially said, no, we're not going to let them move, law was the same then. And then when you made the decision earlier this year to say you could move, what changed in the department's analysis?
I think that, part of it was what was changed in statute, kind of goes to the things that we felt needed that were kind of missing in that ability. There was not much written in statute or rule, to be honest, that laid anything out either direction, right? So the arguments could have been made either direction to do it, and obviously I think the department felt at the beginning that we had good standing to not allow it. As far as what happened and on what levels, I don't know. I can only talk about what I know, and at some point in the year, we were told.
So just a question for probably someone else. Sounds good. I appreciate it. Okay. And then I guess my only follow-up question is, probably two more, sorry, I keep asking, I got a ton of follows. It's like we're in a deposition, right? Gives me 5 more questions. So first one, as far as the replacement pharmacy in Springville, I've heard kind of informally that an RFP is going to be released in the next 45 days with the hope of issuing the license before the end of the year. Is that right?
Yeah, that was really my timeline as far as that's been told out to people that have asked that after this letter comes out. Our hope was that there was the ability to talk to the groups today, MCPAB being one, and then the legislature's executive appropriations committee being the other, required by statute before we open that one. That's which them. And then with that being said, our hope was to spend the next month working on an application type of thing. Well, we believe we'll be using, what we'd like to do is actually use the department's system that they use for grant money type of thing, and change that, and that's how it be. So yeah, the timeline was again a hope to get there by January at least, and then as you guys all are aware, that the law allows for any license to take a year to get moving. So just I think that timeline obviously is being pushed back. We'd like to get it done if it is something that's going to happen, obviously as soon as possible. But that being said, Alex, we're still kind of on the hurricane wave portion. Once we know what direction it is, then we'll start the direction it's maybe there's nothing that happens. If there is an ability to open another one, then we'll start that process. And then we're hoping that it is the time that this happens, but that being said, right? Got to take time to write the new application. We got to review however many come in, right? And that actually almost to the board, right? The department's only stance in that aspect is to make sure the applications are right. That then the information that's part of those applications will be reviewed by the licensing board, and then they'll score those, and then based on that, it's how we award the license.
And then the presentation to the appropriations council for today, was that to also explore potentially additional licenses beyond the one in Springville?
Yeah, yesterday, Vickers said Ward, and I had Amber to my right, and her head snapped quick, and that I didn't get Brandon's look on his face. Yeah, that's what was said yesterday.
But still though, right, that should all, I understand the legislature can do what it wants, but the way the law is currently written still gives you all the authority in conjunction with DHHS to study the need for additional pharmacies, right? So the way the law is currently written, you all, based upon your own analysis, should be able to determine the number of additional pharmacy licenses.
Right. So yeah, I believe the statute says something to the effect that we do have to meet with the Department of Health about that. That has taken place. And then the next steps were that, and like I said, I think once we knew for sure that we were on, and when I say the Department of Agriculture, we're on the agenda for the Executive Appropriations Committee is when we reached out. And we just like set on the phone call, so I asked them to put on that. This is what's that like to change things. Okay.
Anyone else have any comments from the board at all or questions? Yeah, I think really the only feedback I have is, and this kind of, obviously this is not a quick, you already answered the question, you don't have the answer to the timing. I just think going from October through an entire legislative session, making changes where they couldn't make a move, and then all of a sudden by October, you find out, yes, they did get an approval to move. I think if anything, it's just more communication, openness. Just understanding, hey, you know, there is gonna be a change. And I mean, it's impactful to the industry. Yeah, and obviously it affects patients, so.
Yeah, if I could, Matt, on that, and I know that this is a different situation because of the thought process on how it affects the industry and also patients as well, type of thing, but it's never been the department's stance to talk about other people's change requests publicly to that, right? I mean, that it's just so trying to split that hairs, and I know that there's an argument because of us, that's what you mentioned, type of thing, but until things are actually done and put in place, that we try not to put much out there until we know for sure. As you all know, who have done a change request, just because you get an approval letter from the department does not necessarily mean that actually goes into effect for some amount of time.
Yeah.
So.
This wasn't one that went through to the board though.
No,
Is
there's
this-
nothing about, this was nothing
Okay.
about boards that do that, but there's also things that don't go to the board even still for your producers, so.
All right, with that, I don't think there's any other board comments. We'll go ahead and open up for any public comments here in the room and then anyone online if they want to raise their hand for preparations.
Bijan with Beehive. We have a rural pharmacy and an urban pharmacy in Salt Lake. And love working with both departments. This is probably the first time we feel like this decision has not been in industry's best interest, operating in other states. Packaging and some rulemaking things are less impactful to the stability of the marketplace. While we have a limited number of patients, we've now foregone those patients in Utah County to now serve the same number of patients in Salt Lake County. So from an operator's perspective, just to put it out there, these type of industry impactful decisions do impact the longevity of the program, the longevity of operators. I've divested in every other state to focus primarily on Utah. And I've been the one beating the drum, like, let's not make the same mistakes as other markets. And while we look at the fine line of access, we also have to make sure that there is a path for longevity for operators to survive. Otherwise, we have no industry. So I do ask both regulatory bodies to really consider the individuals who have contributed a massive amount of resources and time to also work with you to stand the program up to make sure that future decisions don't end up taking one step forward to putting two steps back. But it's hard to put the genie back in the bottle. And when other people try to follow suit, you have to put guardrails around such. So as a local operator here, my main focus in every day is how do we maintain longevity in this program, because markets around us are imploding. Look at Colorado, look at Nevada, look at California, Arizona's heading there. So how do we learn from industry? How do we learn from other markets? So thank you guys.
Alex should be next. I'm just follow the same pattern.
Gareth with Dragonfly, piggybacking off of Bijan being another local operator, born and raised in this state, being locally invested in this state, caring deeply about community. It's tough to see when, you have the right relationships, the right loopholes, the right angles, you can kind of get what you want. And that's a challenge when you do have to deal with MSOs. Like, they're going to be aggressive. They're going to do what they can. They're going to find whatever possible way that they can, right? Local operators don't have those same resources. We don't have legal teams, right? We don't have huge teams that can look through all these loopholes to find areas of opportunity to win and compete. So as a local operator, our only chance is transparency and to be able to play the same game as everybody else, and knowing what the rules are to establish, to be able to make a move, the rules to establish to when a new license gets awarded, and how we could potentially compete for those licenses. And that's the most important thing. Transparency across the board of how do licenses get issued. And I still don't think that we have a clear roadmap on what that actually means. And you guys have the power to make those decisions and determine that analysis and clearly provide some rules in the sand that say, look, every 15,000 patients we add to the program, we're going to add another license, right? And we're going to add it to these areas because that's where the need is. That allows us as local operators to be able to plan, strategize, and at least have a fighting chance against people with a lot deeper pockets than us.
I don't see there's anyone online. Oh, we do have one.
Mike?
Blake, you'll be unmuted and state your name and affiliation.
Blake Smith, Zion Pharmaceuticals. Thank you for allowing me to speak. The one comment I have a couple comments, but first, I think the most important thing that was said was about transparency. Having conversations about changes in the industry and things are pivotal for all of us to be able to decide how to best respond to our patients and also each other within the industry. So transparency and talking is important, but I'm actually a little bit floored that the Department of Ag is allowing all of you to almost depose them, not to attack JD on this, but the Department of Ag doesn't answer to this board. There are probably lots of reasons why a lot of things happen, and I appreciate what Cody says about not airing of dirty laundry as companies are trying to make changes. We're all trying to do the best things we can possibly do to ensure that all of our patients are receiving the best quality they can, and that includes business decisions and working with the state. The state has done a great job at helping us do a lot of these things. And working with individual companies, I don't think there is any nefarious action on any of this. It does affect the industry, though, and having communication would be helpful. But at the same time, I don't think anyone on this board has the right to go after the state on this particular issue. What I do think is we should all be working together to come up with rules that work for all of us to make this go. And so I don't think this is a board for us to air each other's dirty laundry. And this feels in poor taste, this discussion around what's happening with an individual company.
Thank you. And I'll bring it back to the board and just kind of answer there. I mean, the intent of having this topic was not to air dirty laundry of another
Yeah,
operator.
it's certainly not the intent of any of the questions.
No, the point of allowing comment on here is that there was a lack of communication once, obviously the letter we got. And that's all we were trying to find out is what was the intent and when was it known? And in the future, if there's a change like this that changes this, I mean, even under statute, any one of the existing operators can move within their region. There's nothing stopping them from moving. But that does impact those around them. It impacts patients in those other areas that if they decide to get it removed. It could be detrimental to the program or it could help in some situations. And so I think what really that's all I'm gonna say. We did have someone raise their hand as I was speaking, so we'll go ahead and allow her to get 2 minutes. Patty, you can go ahead and state your name and affiliation. We cannot hear you, Patty. Your microphone is working. If you're able to figure that out, you can just re-raise your hand. And all right, well, we will go ahead and there really wasn't any board. Well, I didn't think there's anything in there, it's just more to bring that up. We'll go ahead and move back on to item number 7, which is the pricing transparency.
Yes, and can you hear me? Yeah. And Representative Daley Provo is here. Can we how does that work? Can we just allow her to like co-present, or do we have to like do something fancy?
You can unmute her.
Promote her to a panel instead of saying.
Thanks for having me.
Yeah. So I'll kind of get started, then just kind of introduce it and then turn it over to Des to see if you have anything you want to add. But in the last medical cannabis working governance group meeting, Rep. Daily Pro was brought up. She'd like to see something around pricing transparency. And one of the things that a lot of patients kind of, when they provide feedback is, and this kind of goes back to the cost. We talked a lot about costs today. But they want to be able to easily access and see where their medication can be, A, be found, and B, what's the actual cost of that medication. And so there's been a lot of discussion in what does that look like for the industry? And secondly, what is the need for patients? What are they accessing? Is that we're kind of throw some things that I've heard and we've talked through is it a website? Is it something that's accessible within the pharmacy that they're able to see? The breakdown of costs and things like that. So Des, I'm going to turn the time over to you to elaborate on kind of what's expected.
Yeah, so we've talked about a couple different things, especially with processors not being able to kind of advertise where their product is going. So that was one piece of this, and then also just like being able to know the cost before you go in, or comparables, being able to compare cost. And so that was one of the things that and consistent access to the same product has been a problem from the beginning. So so those are some of the things that we are kind of hoping to attempt to solve with this. And then if Representative Daly Prowler, so she spoke up in the last meeting about that she was interested in creating like a cost comparison tool. I envision it something similar to like a Leafly, where it says the products, where you can get them, and maybe even go into like what they are recommended for. But all of that is still to be talked about. So Representative, if you want to say your part, and then we'll have a discussion.
Sounds great. Thank you. And thanks, Des, for coordinating this. I really appreciate it. So as was mentioned, we talked about this in our last oversight committee meeting. And for anybody who, I'm sorry, I've not been part of the whole meeting, and I don't know how much everybody knows, but this is our group of state legislators that are statutorily tasked with working with this board and industry and our regulatory agencies to do our very best to make sure that the program is meeting the needs of the patients in the state of Utah. And one of the needs that has, as Des mentioned, perpetually come up is just this inability for patients to get good information on accessing medicine that is consistently accessing medicine that works for them, and consistently knowing, the best price that they can get for it, like any other product that you would have access to buy. And I recognize that this is not just any product, and that we need to be intentional and careful about how we have this conversation. And so we started talking about this last session. I actually had a bill file and started working on it. It wasn't until the very end of session. And so there are a handful of stakeholders that have started to conceptualize, and I don't know if it's going to work, but one of the things we talked about was creating a website that would be hosted likely at DHHS or at UDAF, that could only be accessed by somebody who was a card holder. And so there would be that limitation, so that it wasn't just full public access, because there is a lot of heartburn with a lot of my colleagues about people accessing information about medical cannabis that they shouldn't have access to. And I mean, that's a philosophical discussion that I don't necessarily need to get into. You can all imagine what the arguments might be for or against. But just being able to create that portal so that patients can do price comparisons and say, I found this medication, it works for me. But for some reason, the last time I visited my pharmacy, it was 30% higher. And does anybody else carry it? Can I find it somewhere else? And so I think that one of the, somebody who has a pretty strong business background, one of the best ways to limit costs is to ensure that there's a supply and demand mechanism, and we don't have that right now. And so my goal in the price transparency, whether it's that website or some other mechanism, and I'm not tied to that idea, what I would like to do and why the reason why I'm here today and excited to have this conversation is that I want to make sure that we have created a forum for stakeholders to come to the table and have this conversation. And I did make a call at our last meeting saying, if you want to be a part of this conversation, you need to send me an email. And that was very informal. And I recognize that. And, you know, it also ensures that not everybody who would be interested necessarily got that message. So I'm hoping for the help of this board and people that attend to kind of get that information so that people who want to be a part of that conversation can express the interest in being part of that conversation. So I will lean on the board, this board here for this group, to make sure that the email address for staff and myself are published somewhere so that people can send that request and we can work on the very challenging issue of finding a time that people are available for a Zoom meeting so that we can have that discussion. And it might be, in order, you know, in the interest of efficiency, it might be that this board designates a handful of people and that handful of people actively gather input and feedback from their, you know, their own respective communities. That might be the most efficient way to do it. So you've got kind of point people representing, you know, the community that you represent. You've got a patient representative, you've got a representatives from industry, from pharmacies, growers, processors, state agencies, et cetera. So we're not formalizing it, but the goal is just to get as much feedback as possible so that we can do something, because right now doing nothing is not tenable. So those are my thoughts.
I have a question. If we have a couple of the members from this board kind of join a committee to look at this, do we have to create, if there's more than 3 of us or 4 of us, do we have to create like a subcommittee underneath the MCPAB board, or do we don't need to?
No, because this is me as a bill sponsor pulling together stakeholders to have a discussion about a bill. So it's not a formal legislative meeting. It's me information gathering for the benefit of legislation that I'm drafting.
I mean, Des, if we were to formally create a subcommittee, we can do that of board members
But you could also do that. Yeah, that's true.
I just didn't know.
Or you could do it individually in your non-capacity as a board member too, to meet and help with this. That's perfectly fine. I think. Are you thinking about a quorum?
Well, yeah, I was just wondering, because wasn't there some rule that there couldn't be more than 3 or 4 of us discussing cannabis at any time, even outside of this board? Like we couldn't go to the park and talk about it?
We can't have 5 people get together for lunch.
Okay.
Gotcha.
I mean,
Now,
okay. So maybe consider that.
you could have Matt and Des attend as the chair and co-chair of the board, and then I, in theory, could also appear on behalf of Wholesome.
Right.
Judy could appear on behalf of DPS. Annette could appear as a patient and the mother of the patient. Ken could appear as a member of the public or whatever would that cause a quorum?
I think legally.
Regardless, right? Regardless.
Yeah.
Okay. I guess you'll be attending and setting else.
So, I mean, I think kind of to go to the point, I think as a board for us, it'd be good to have that input, especially on such an, obviously, the entire topic today, talking about themes, all been about patient cost, right, and accessibility. And I think what we're looking at with this is how do we make it more transparent, but also how do we make it functional for patients? Because I hate as a producer when I get calls saying, hey, where can I find this product? And I know where we ship things to. I don't know if it's available. I don't know if it's at access, because as a pharmacy, they have the ability to put it as an active product, meaning it's available for sale, or it's not for sale. So we don't see it on their website. Websites can change quickly. And so what product that is available right now could not be available at the time they drive in. That's just the limitations of that's consumerism. You buy a product that sells out sometimes quick. And so I think for us, there's a lot, it is a huge task at hand. But I think when you look at it, to simplify it, for me, the goal would be, is there a method of which a patient can easily access? And what Representative Daily Probst brought up at the website, I know I've talked about it multiple times in other meetings, is I think that we already have a website. We have a state website that patients access. They have their EBS. That's already filtering out non-card holders. It allows a method for which patients can find what products are available at any time. Now, the functionality that we've been using for the last 4 years with MG Freeway probably wouldn't have had the capability of providing the information for a state website to give accurate information. Hopefully through Salesforce and the new data website, that allows a little bit quicker connection to where they'd be able to get that information accurately. And I think it's not just looking at pricing, it's also, I think, answering what we've talked through in here is maybe it's a website where the COA is available. Patients can see batches, they can see separate things. It's not just, hey, here's this flower, it's Northern Lights. There could be 2 or 3 different batches throughout the state of Utah that are growing right now or for sale, and they all have different variations of terpene profiles as well as cannabinoids. And so it's looking for the right one for the right fit. And that's really what I kind of, as I saw through this last night and the last couple of days, what that would look like. I think as a board, I would be happy to recommend and make a motion, do we just have Desiree and I as chair and co-chair? Because we don't want to have a quorum, and then we work with each other in the board as kind of like if we're heading a subcommittee. Or is it something that we do individually as a collective?
If it helps just to make sure that we don't run afoul of any restrictions on people being in the room, I can also meet offline with any of you on 1 or 2 off. I'm available to meet and hear what you have to say, and maybe one-on-one discussions just provides a safe forum for some people that have, thoughts that might be more controversial. So just know that I'm available as a legislator, as a bill sponsor, to have those conversations one-on-one or in small groups as well. It doesn't have to be a formalized big stakeholder meeting, although I do feel like we need to have a couple of those in addition. So I just want to put that out there. And my email is on the legislative website, so you can find it and send me an email.
I don't know if it's possible to have a joint meeting between this board and that group. That could be possible, but I'm not entirely sure.
You're talking about the medical cannabis governance.
If we can hold a joint meeting, then you can hold a forum. But obviously that's more official.
Yeah, it's a public meeting.
Correct.
Yeah, and I would have to run that by the chairs as well. Ultimately, they make the decision as to whether or not we would do that.
Yeah, I think no matter how you do it, I think you do, smaller group meetings, just making sure that anyone who wants to attend, right? You don't have to say like, well, hey, we'd love to have you attend, but we'll make it a public meeting if you do, just so everyone can voice their opinions, because based on what Matt said and anyone else has said, this could be something as small as just where can I find this product and at what price?
Yep.
As a and then you could balloon to every single thing about a product all the way down to how many milligrams of CBD does it have in there, right? And so I just think it's I think just making sure that we get all the appropriate perspectives, of course, not running afoul of the law. Sports done a good job, making sure we very well discussion. So just all
Anyone else
Great.
have any comments or thoughts? I don't know. Obviously, this is more just kind of a discussion basis. This is active. It's something that we want to try and get more information to help before their next meeting for the working governance group. which is in October. And so if we can provide not only Rep. Daily Provost with information, but also her other board members and really the other legislators that would be drafting and helping her with this law and getting it passed. I think there's a lot of things that we can get to help this industry. And making, whether it is a small change or something huge, and let's start with wins and hopefully we can get something out there quick that people are all on board for. Yeah, that's all I've said. If there's no other board comment, I mean, we do have some people that signed up for some public comment on here. We'll go ahead and move it to the public comment for those in the room, and then if not, anyone online, if they want to raise their hand if they'd like to make a comment, so we can get in the queue.
Hello again, Bijan Beehive. I think the intent of this is great. We're all trying to get patients as much information as possible. I want to ask the open-ended objective question. Do we know fiscally how much it's going to cost? And are we putting time and money and resource into something to be built where right now we're in the middle of transitionary technology systems and the rollout hasn't been as ideal? So I just want to make sure that we're not running into a similar thing where we're trying to jam a square peg in a round hole quickly and throwing additional resources and time and effort and people. So I just want to make sure that we're looking at it holistically to make sure that do we have the resources, do we have the people, do we have an effective timeline? Otherwise, we're going to be putting money and resources at something while we're also making major changes on the back end with our Salesforce switch. And I'll be done shortly with our Salesforce switch and our point of sale switch. So the intent, phenomenal. Like we've run into some issues as a retail operator where a patient might look at our menu, drive 30 minutes, and when they arrive, it's sold out. So we train our staff to let people know, put an order in online, we save your order for you until the end of the day. So I think as operators, we can also, regardless of what path we take, operators, we can all work together as industry to help relay information and make it easier for patients to pick up what they need.
Thank you.
Eric, the Dragonfly. Yeah, I think, this is certainly all doable, right? This is, being able to have a central site where all this information is pulled. Really easy to do. It happens in every other market. You go shop for airlines. You can find every single price of an airline and the flight. But it also takes the right team and the right skill set, and software implementation is not the strength of us. So that's something that I think we've just got to make sure that if we're going to spend time and energy and resources, similar to what Bijan said, that we're spending it in the right areas. And I guess maybe one question I would ask is, we kind of did this very similar thing where we spent money and time and energy and resources to create a site where you could go find information on how much a QMP costs is. I'm curious how that's even being utilized, how that data is being kept up to date, because I don't know how useful that tool has been. And I'd love to understand what the engagement of how many people actually click through and look at that cost on the department's website.
Alex Orge with Wholesome Co. I appreciate Representative Jen Daly Provost joining us. And she did mention that she may have missed earlier parts of the meeting. There was a vote to commission for the legislature to commission a study. I would love for her thoughts on the ability to study the pricing in our state, and if that's something we think is something the legislature, and obviously she's hearing about it now, would reasonably support. I think that could go in hand in hand with something like a price transparency tool. I think that it's going to cost funds, and the legislature is going to have to decide if they want to have a better understanding of this industry and the pricing, that to put resources behind it. And I hope they will, because we do want a study like the one that we've seen from the Department of Ag about the patient access. And I think that if we are able to get the resources, we're going to be able to find the answers. And if a price transparency tool is going to be helpful for patients, we should know that. We have something similar on the QMP side, right? That I don't know. I've never heard whether or not it's effective, but it is a tool it's there. I think it has been effective. So looking at, some of the transparency tools that we have and then where we should go to build it and how it should work is going to take a lot of discussion. So, Representative, we definitely want to be involved. And we will make time for whatever we can to help, provide insight and input so that these tools work out for the patients.
Thank you.
Is it okay if I respond to that real quick?
Yeah, go ahead.
Awesome. Thank you. Yeah, I apologize that I wasn't able to attend the whole meeting. I actually teach and just I had my hour-and-a-half lecture was right in the middle of your guys' meeting. But if it's okay, I will work with the chairs of your committee on that study, commissioning that study to make sure that I understand what the goals and process and outcome for that are, and figuring out to the best of our ability where this price transparency piece fits in with that, so that number one, we're not duplicating efforts, and number two, if you're already doing some of the legwork, where we can just add this on and make it efficient. So that's great news. Thanks.
Were there any, doesn't look like there are any online public comments. No, I do appreciate everyone's input, and there's a lot of things that we'll work with. Des and I will work with our daily provost on this and try and see what we can add for future meetings. And they should definitely email all of you the link from if there's something that we're talking through. This is a huge work in progress. I mean, Des and Annette have been working on patient costs for 3-4 months, and it's every time they think they're getting somewhere, something else opens up, and it's everything they thought is now obsolete. And so it's really starting over. And so I think for us, for the sake of the market and the industry, is getting something that's functional. Can be expensive, it can be affordable, depends on what the scope of it is, and if it's well defined. So I think we're at a good position where we have time to make recommendations to the legislative team to draft something that can be effective and efficient, and which most of the times it's about negative, but we'll work through that, right?
Of course, sir.
So, no, I appreciate everyone's time. There's not really any motions or anything on this that I can think of. Does anyone else have anything else they'd like to add before we move on?
Just one
Yes.
comment about the medical cannabis cost visit website. It still is used by patients. Last I checked, I think there was between 200 and 300 visits per month, and but that I know it was really high at the first, and then it might have gone down, but I can provide that data to the board. Also, there's a statute that requires that it be updated quarterly. And so we are following up with clinics quarterly to request that they update the information that they're providing there.
No, right, that's all. No community is required to participate in that. So
the requirement to place your pricing on there comes if you advertise publicly that you are indeed recommending medical cannabis to patients. If that's advertised publicly, that's the trigger for being required to post it on that website. So there's hundreds of them that do it today. We follow up with them, and we first give them a chance to be honest with us about it, right? And then we'll do spot checks, random sample, and see what they're saying. And if there's something that is not accurate, then we'll reach out to them. Also, patients can audit themselves and let us know. Sometimes we'll get notified by a patient that the pricing isn't quite what it's reported to be.
So if, for instance, a clinic or a QMP doesn't advertise their services publicly, are they still on that website for people to be able to find them or not?
Say that
Like if
again.
they're just trying to locate a medical provider, right? Because I know you can kind of use that as a tool,
Yeah,
you know, to find a medical provider. If they don't advertise publicly, which requires them to then be transparent about their costs.
yeah.
Are they still on that website for purposes of finding it?
No, but they're on our website.
Your own website, so people
Yeah.
can still find those other options if they want to, and or all medical providers that are actually. doing this.
Yeah, but some medical providers specifically request that they not be posted on our website. And we allow them to do that just because they don't want to be contacted. They just want to be available to their current group of patients.
Other patient that encourage that.
Also, I just got an update, in July and August combined, it looks like there was 7,600 total views and 4,900 users during just those 2 months. So that's July and August. Yeah. Yeah, that's
So
where-
one thing with that price compare, which I love it, but I get complaints from patients, and maybe this is something we need to work out in statute this year, but that they go to the cheapest one in the area and maybe they're saying like, oh, it's $50, but then they're like, oh, it's $50 a month that you have your card. So there's these hidden fees, right? They put their number very low on that website and then charge something different. And so, and that was very common up to a couple months ago. I haven't checked on that website super recently, but they were definitely saying, there was people that were advertising $10 cards, but then when patients would go in, it was definitely closer to 100 by the time all the fees and everything were put on. So that's something that maybe has dropped people coming to the site, is because they're just no longer getting adequate or accurate information on what it's going to cost, because people aren't putting the right price. And maybe we just change it to you have to advertise your yearly amount of a cannabis card or something. I don't know.
Yeah, and just to clarify, what we've noticed is an increase in use of the website, not a decrease.
Okay.
Yeah.
Well, hopefully.
I think some of that
Hopefully-
is there's more medical cannabis card holders in the program. So more are checking in as we get more card holders.
Well, we'll go on real quick. Ahead of schedule, always good, but so our next meeting's agenda. Are there any topics or anything that anyone wants to get added?
And you should start having.
Yeah.
Started to discuss. Yeah, don't know if we want to discuss any of the priorities that were listed yesterday. Say most of us attended, ourselves attended. Yeah, most of the service. Yeah, it's getting a lot of time here.
Yeah, those are the two things I looked at for the meeting, is what does the governance group have on their agenda? Like I said, we did move up our meeting 1 hour in order to make it up to the Capitol for their meeting. So that Des and I mean, we'll be asked to share kind of our thoughts on what we've been working on as a board. And what we're meeting on. Yeah.
To at least discuss. And take action or anything on this, but the agenda's gonna be for October, and then always come out, super far in advance. And we at least have talking that to talk for at least 30-45 minutes to any board members can formally be dead, but they're having discussions that day. Because I imagine there weren't some follow-up stuff, but I imagine there might also be some new items.
Yeah. And I do have the list of legislative priorities. If there's any specific ones we want to help with and get what industry support on. I'll meet with the stakeholders and see what we get added for the specific items. So, is there anything else in the board, anyone online? Very good. Okay, if nothing else, we'll move to the next item and. Maybe Jimmy?
Oh, yeah.
All right, it's been seconded and it is unanimous. Thank you very much. Thank you, guys. Getting